Welcome all to this webinar on clinical cardiology and the role of echocardiography by Dr. Kasliwal. Dr. Kasliwal is an adjunct professor of cardiology, and he's also the program chair DNB Cardiology, Medanta Medicity. And he's also the chairman, clinical and preventive cardiology. And he's also the president of South Asian Society of Atherosclerosis. And he has also been the past president of the Indian Academy of Echocardiography. I'll now hand over the session to Dr. R.R. Kasliwal. He will take us through the role of echocardiography and in clinical cardiology. Please, Dr. Kasliwal, you can now start the session.
Yeah. So, boys and girls, ladies and gentlemen, I have been, from the very beginning, interested in clinical cardiology. I've done interventional cardiology. And when echocardiography evolved in India, I was at the forefront right from then, when I was at the All India Institute of Medical Sciences. So I've divided this today's interaction into two parts: the journey thus far and the relevance of this investigation in the Indian setting truly. So let me start with the journey thus far. If you remember, those of you who like history like I do, then the anatomy of the heart was first described by Leonardo da Vinci. He lived between 1452 and 1519 and gave a good description of the heart. And then William Harvey, who was born on 1st of April 1578 in a small town in the United Kingdom, actually demonstrated circulation of blood and how it takes place. And then came René Laennec from France, and he was upset at putting his ear towards somebody's back and then hearing the rals. So he developed this structure, and later on, stethoscope. The stethoscope actually became the hallmark of a physician. This was René Laennec, 1781, 1826. The time has come when the stethoscope is being given over and people say that we should see everything. How did this start? Inge Adler and Hertz, 1953. Inge Adler was on the beach one day with his child. The child kicked a small part. He said, "Dad, what is this?" This is after the Second World War. He said, "Son, this is a part of the periscope, which is used by the submarines to find out an enemy submarine or a whale. It uses the principle of sonography." And so in Sweden and the Scandinavian countries, it became very common. Ultrasound came later, echocardiography came much later, but it was sonography which became popular. The two people behind this were Inge Adler and Hertz, 1953. This is how ultrasound was done in early days. Can you imagine? You almost had to soak in warm water, and then sound wave portrait was seen. And this was the somnoscope reported in the Life magazine in 1954. And then over a period of time came the standard transthoracic echo. And this is what we are going to see. People think that a transthoracic echocardiogram is a very basic investigation. And looking at this is one investigation, which is the eyes of the investigator. You add Doppler to it, it becomes the sound of the heart. And of course, when you put color into it, you can see the regurgitant lesions. So it's a powerful technique, correctly applied. It can give you the diagnosis when you didn't think or you thought something else. This was the birth of transthoracic echocardiography. But before transthoracic, but the first thing that came in was M-mode echocardiography. And I started my life in 1977 at the All India Institute of Medical Sciences in New Delhi with M-mode echocardiography. And this is, in front of you, is the mitral E and A waves, the anterior mitral leaflet, as first seen by Adler and Hertz echocardiogram. They were unable to see the posterior leaflet at that point, but even with this, they could diagnose thickening, and they said that maybe this is hallmark of rheumatic heart disease, which was pretty prevalent all over the world at that time. So this is how M-mode echocardiography developed, and I was even at that time convinced that this technique will go a long way because it was something. So from M mode, we developed two-dimensional echocardiography, and I'll just give you a very brief overview of it. But see, in actual figure, you're able to see the aortic valve, you're able to see the left ventricular cavity, you're able to see the LA, the right ventricular outflow tract. And if you look at it, this is exactly what you can see in a in an echo, and you can see the moving picture. So this was a revolution that happened. That from ECG, X-rays, and angiography, we also had something which could tell us what we should be thinking, what is the disease, and then do and go accordingly. Here is another picture of parasternal long axis view. You can see the aortic valve here. You can see the aortic valve here, closed position. You can see the aortic valve open position, and you can see on echo in the opening position. So even though you are seeing a slice of the heart, you're able to perceive that yes, we are able to diagnose conditions by echocardiography. And this was a huge change. It was a change beyond belief. For example, here, this is a short axis view, and in the short axis view, you can see the contraction of the heart. You can make out what the ejection fraction is. And on the other side, you can see that just as in the real specimen, you can see the thickened LV walls, you can see the anterior papillary muscle, you can see the papillary muscles here, you can see the right ventricular outflow tract. All these things are seen in real time. The beauty of echocardiography is real time. You can visualize the whole thing. So this is a short axis view. And the addition of color added a new dimension. You could now see the regurgitations, you can see the other structures very clearly. And I will give you an example. But just see, in this specimen, you can see the aortic valve and you can see the interatrial septum, exactly what you can see in real life. And I tell you that in real life, by the use of echocardiography, you can actually see things which were not even visualized previously. You can see the interatrial septum, you can see the tricuspid valve, you can see the aortic valve, and you can see the septum. So you can find out if the patient has ASD, if you can find out if the patient has a VSD. All these things are now possible just by the use of a 2.5 megahertz transducer. These are the apical views. You can see very clearly aorta, RA, RV, whatever you are seeing, the same things you can see in the apical four chamber view of a patient while the patient is comfortably lying. You can see the LV cavity, you can see the mitral valve, you can see the left atrium, the right ventricle, the right atrium, and the interventricular septum. You can see the complete uh, walls of the, and in many views, all 17 segments can be visualized. So this then very briefly showed us that from the time when Leonardo da Vinci actually showed us what the structure of the heart is, now you can see it without any pain to the patient, any radiation hazard to the patient, left lateral position, transducer, and you can see all these things. Moving next, sometimes we could see that yes, the valve is leaking or the valve is stenosed, but we didn't know the gradients across those valves. There, Doppler echocardiography came into view. And here again, I will take you to a brief history. It was Johann Christian Doppler from the University of one of the universities in Austria who defined the Doppler principle and the Doppler shift, and that became the basis of Doppler echocardiography. Look at this. We have put a sample volume on the mitral leaflets. You can see the blood flow from the LA to the LV, E wave, the A wave. I'm not going into the scientific nuance of it right now, but this is one way by which you can actually find out whether the patient has any diastolic abnormalities or not. All the while, we were concentrating on systolic abnormalities, and now we can even talk very, very correctly about those patients who have stiff ventricles or whose hearts are stiff and not and there is abnormality of relaxation. Similarly, here we can get the gradients across the tricuspid valve, across the aortic valve, across mitral valve. So not only can we diagnose these individual stenosis or regurgitation, but also in combination. That the patient has severe MS, but also has AS, you can diagnose. I can tell you it used to be a very difficult job when we used to do cardiac cath and then define these things. Color Doppler, you can see very clearly. You can see the left ventricle here. You can see the enlarged left ventricle, and you can see the flow of blood into the left atrium. What is this? This is regurgitation. Without putting any dye into the left ventricular cavity, you're actually able to define mitral regurgitation. And same thing you can do for TR. And TR is important because you can actually define PASP pressure. So hemodynamics is another area by which you can tell your clinical cardiologist that, sir, here is a patient whose PASP is high, inferior vena cava is dilated, tricuspid annulus is wide, probably has got a dilated cardiomyopathy. So the benefits of echocardiography, it's totally non-invasive. Of course, there are now other nuances of echocardiography in which we put transesophageal, and that is invasive angiography, but echocardiography. But what we're talking now is a totally non-invasive technique. It has no radiation hazards. You can use it in pregnant ladies as well. It is easily available. It can be done at the bedside. Assessment of cardiac morphology and hemodynamics. That's very important. Hemodynamics in real life, in real time, is very important, and you can see the results immediately. So it's available. It's not very expensive. Can be done from the ER to the OR. You can do echocardiography wherever you wish to do it and save a person's life. Now let me take up just a few examples why it is so relevant in our country. For example, rheumatic heart disease in South Asia. If you see this week's issue of circulation, they have said more than 3 million deaths globally and loss of 10 million disability-adjusted life years occur because of rheumatic heart disease. Well, you can diagnose rheumatic heart disease very easily with echocardiography. Here is a patient with mitral stenosis. But if you take 2 steps backwards, patients who have even thickening of the mitral leaflets, you can diagnose. And you can save these patients just by the use of Penidur injections, by penicillin. Other valves as well. You can diagnose mitral regurgitation very clearly. And you can diagnose aortic stenosis as one example I'm showing you. But the point is, you can diagnose tricuspid stenosis, pulmonic stenosis, aortic stenosis. All these conditions can be diagnosed by transthoracic echocardiography, and this becomes the very basis. Now, nobody will do a cardiac cath to diagnose aortic stenosis. Everything, even the placement of a transaortic valve replacement by a cardiologist, the TAVR, as we call it, TAVR, is done on the basis of a correctly done, diagnosed severe valvular aortic stenosis. Here is an example of mitral valve prolapse. Again, important thing we have is dilated cardiomyopathy. Young lady, she gives birth to a child, has dyspnea on exertion. The obstetrician calls you. Just by this, you can by the echo, you can diagnose dilated cardiomyopathy. Heart failure, again, very important. You can diagnose heart failure. You can see this ventricle is so thick, poorly contracting. Heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, heart failure with mid-range ejection fraction are all based on 2D echo delineated ejection fraction. Whether a patient with 25% ejection fraction will he or she require a a pacemaker, whether it requires an AICD, all these decisions are taken by the use of correctly applied echocardiography. So you see how much difference you can make to a person's life by doing echocardiography and clinical cardiology. Again, diastolic function, as I've already alluded to, is again extremely important. Patients with diabetes mellitus come to you with breathlessness, and you can always say, well, angiography is normal, here it is, it's because of diastolic dysfunction. Longitudinal strain is again something which you can do just by 2D echocardiography at the bedside, and you can demonstrate that even though ejection fraction may be normal, you can actually say if there is ventricular dysfunction because of global longitudinal strain may be decreased. This is called GLS, global longitudinal strain. Cardiac masses, you can diagnose very clearly cardiac masses in the body, in the heart. See how clearly you can see here. Good LV function and a mass going up and down. Now, many a times when the patient comes to you with chest pain, we are ready to thrombolize the patient, or we are ready to take the patient into the cath lab thinking this is maybe an acute MI. But see, if we had given heparin or aspirin to this patient, he would have been in deep trouble, because here you can see a dissection flap so clearly. Of course, you might have to do a CT later on, but at least you've made a decision that here is dissection of aorta. Every chest pain is not an acute myocardial infarction. So the role of echocardiography in the 21st century is huge, huge. You can establish diagnosis. You can demonstrate the severity of the lesions, supposing it's a valve disease. You can define how severe the aortic stenosis is, because you can get hemodynamic information. What is the mean gradient? What is the peak gradient? What is the tissue? What is the VTI ratio, called the dimensionless index? And that will help you in planning the course for this patient. Every patient with aortic stenosis will not, if it's not severe enough, or aortic regurgitation, for example, will go for medical therapy and will come to you 6 months or 3 months. So you can plan. You can plan medical follow-up. You can plan intervention. And in intervention, you can plan, should this patient be going for TAVR, for SAVR, or for surgeries. And therefore, echocardiography has helped you in overall management of the patient. In our institution, almost 200 2D echocardiograms are done every day because of the volume of clinical cardiology, and because it helps in everyday, day-to-day practice. I will take 2 minutes to talk about coronary artery disease, but I'll put it in perspective that heart disease, as Picon said in the Jack editorial, is the #1 cause of mortality worldwide. If you look at India, India has the highest rates of cardiovascular disease, much above cancers and other chronic respiratory illnesses. And worldwide, 50% of all cardiovascular disease is as a result of cardiovascular disease. India currently has the highest burden of ACS and STEMI is the common form of presentation, accounting for two-thirds of patients of acute MI. You can easily pick up a regional wall motion abnormality in a patient who comes to you with chest pain, and you can direct the patient rightful to the right place. The current prevalence of CAD has increased sevenfold in urban India and fourfold in rural India between 1970 and 2013, with a current prevalence of 14% in the urban and rural population. So the burden is huge and also affects young people. There are unique features of CVD in India. There are young people getting affected with it, and that's the most important part. That just by the use of echocardiography, not only for early detection, but also picking up wall motion abnormalities, you can diagnose a patient that the patient has coronary artery disease, acute MI, or non-stem. All these things can be picked up by echocardiography. So, and this is another short axis view showing you wall motion abnormalities in the posterior wall. And these things all make you confident that you can diagnose disease at the bedside when the ECG may not be showing everything and take appropriate action. So the reason I showed you the revolutions, the number of patients with rheumatic heart disease and coronary artery disease in India is to emphasize the fact that these clinical conditions can be diagnosed so well with the use of echocardiography, a simply done 2D echocardiography with Doppler, color, and you can actually diagnose most of the conditions. Here again, this is a four-chamber position. You can see that the patient has severe wall motion abnormalities. Some of these patients go from place to place and correct diagnosis is not made. Angiographies, of course, tells you about a lot of things, but many things are not told by angiography, which you can actually pick up by the use of echocardiography. So here is a patient again. You can see the patient came to you with a stroke, and you're about to refer the patient to a neurologist. Of course, the neurologist will see a patient with stroke, but if you look at the ventricle, the left ventricle of this patient has got a large LV thrombus. And if you can, as you can see, this whole apex is actually akinetic, and an akinetic apex forms a place where thrombi can take place. So obviously, it encompasses, echocardiography encompasses literally the whole of clinical cardiology. Interventional cardiologists need you. Electrophysiologists need you for ejection fraction. So if you were to use echocardiography intelligently, and now of course you have point of care echocardiography, as I was saying, that from the stethoscope, the point of care has become so rampant, particularly in this time of the COVID-19 pandemic, when don't want to use your stethoscope, you can actually pick up most of the cardiac diseases just by the use of point of care. I remember reading an editorial in New England Journal of Medicine will say, stop listening but start seeing, and that's how things are going. So with these few words, I've tried to give you a panorama from the times of Da Vinci and William Harvey to contemporary times and to the times of COVID-19, that you, as a person who has done work in has learned the nuance of echocardiography, will be a great help to your cardiologist, to your department, and truly, no department of cardiology can actually function without the use of echocardiography. Thank you very much. If there are any questions, I'll be glad to answer.
Yeah, you can just type in your questions in the chat box. Then I can just put it forward to Dr. Kasliwal for him to answer. So please put forward your questions.
Now we can take the slides off. नहीं, slides off कर देना. You can do the question answers. I can see them.
Yeah, Dr. Kasliwal, actually, I just put a poll question that are you trained in echocardiography? So more than 85% of the students said they are not trained in echocardiography, which is very interesting actually in the context of the webinar. And also interestingly, the second poll question I asked, would you like to pursue a fellowship course in echocardiography? And more than 65% said yes, which is again very interesting actually, considering that they are not trained in echocardiography and are interested in pursuing.
Yeah.
So, I mean, I just wanted to just give them a brief as to what is the future, what is the scope of echocardiography.
Yeah, you want me to speak about it?
Yeah, just a few lines. I mean, if the interested students are really, I mean, want to pursue a course in fellowship in echocardiography, I mean, what is the scope, I mean, after doing that?
No, as I've given this panorama only for this reason, that they truly understand that in every arena of cardiology, because they're all doctors, they understand what heart diseases are, they know cardiology, that in every sphere of cardiology, you will be able to make a mark for yourself. And you will be helping your patient, you will be helping the clinical cardiologist, and you'll be helping your department in forging ahead, both with early diagnosis, as well as correct diagnosis, as well as helping your people in planning out the course for this patient. For example, an acute MI patient, and the patient says, "Sir, I want to go home now, my angioplasty is done." But if diastolic dysfunction says that the left atrial pressure is elevated, you will say, "No, first let me let me give you adequate medications, and only then you should go." Just to give you an example, because rheumatic heart disease, coronary heart disease, cardiomyopathies are so very common in our country that just by the use of echocardiography, you will be able to make a mark for yourself.
There's one question by Dr. Ajay, and his question is, I don't know whether you can answer this now. How to resolve holes in heart during infant stages?
How to resolve? Oh, of course, pediatric echocardiography is a major field, and you will be able to see the hole in the heart, and you will be able to see with X-ray and ECG if the lungs are congested, and if the child is coming back recurrently with colds and coughs, you will be able to tell the doctor what to do about it. You can, of course, echocardiography is being used in neonatal wards so commonly. Go ahead, please, if there's any other question.
Yeah, I'm just... Yeah, there is one question, of course. I mean, he's asking that whether he's doing just completing his internship right now, and whether he can pursue the fellowship in 2D echo, which is actually, yes, he can pursue if he's interested in the 2D echo course.
Okay, so that you already answered it. See, I have not covered one area, two areas, because of brevity of time. Supposing this person does not go to cardiology.
Okay.
But after internship, he goes to critical care medicine.
Mm-hmm.
Today, half of critical care is based on echocardiography.
Very true, sir.
In the sense that any sick patient, whether he has got sepsis or whether he's got cardiac or neurological problem, they'll say, "Please have a look at the heart. I hope that function is normal." And what is the heart? Like I showed you that one patient who has a thrombus, and the thrombus may have actually embolized to the brain. So if he goes to critical care people, I'm actually right now doing 2 theses with my fellows in critical care, and they're not cardiologists, but they need to know about about cardiac output, about ventricular contractility. Similarly, if you are an ER physician, any person coming with chest pain or breathlessness, first thing they will do is an echocardiogram.
Absolutely, sir. Very true.
Yeah. So many related specialties are there. Let me say, see, people who come for knee replacement, for example, they are metabolic, they are obese, they have been inactive. You have to do a dobutamine echo or some such thing to say, yes, now you can go ahead, and there is no danger. So echocardiography has very wide nuance. Obviously, in one class to go through it would be overburdening a young mind. But these several fields are totally clear: cardiology, emergency medicine, critical care, even neurology. A good knowledge of echo will help tremendously. And this person will score over others who have no idea of echocardiography.
Yeah. Any more questions, please, to Dr. Kasliwal? Yeah, I don't think there are any more questions, sir. So I take this opportunity to thank you, sir, Dr. Kasliwal,
No, no
for
problem.
sharing your expertise on the role of 2D echo in clinical cardiology. I'm sure the tremendous response which we got by the sheer number of students who have attended this, I think it goes a long way in showing that how popular this course is, or how interested the students are in taking up this program. So I thank you once again, sir, for taking time out and sharing your expertise on this 2D Echo program and the role of
Thank you very much, sir. Thank you.
Thank you very much.
Thank you.